Preventing contractures is mobility. So we would be looking at how to keep the joints mobile when the person is in bed. So it's again practical problem solving. A lot of you have already been doing that as a carer, as a therapist. So we would really welcome your thoughts on it as well. Okay. Probably.
I mentioned there's a position to help when people spasm. Sometimes when you have a new injury in and they are just after their surgery or they're in their acute phase, they spasm a lot, and when you put them on their back, they spasm into extension because you're lying them on their back and they get a mass extensor pattern, so they're spasming on the bed like this all the time. So we use this position called the frogging position, which actually is just a load of pillows that are putting everything in flexion, and it just breaks up that extensor spasm and can be a really useful way to manage someone that gets a lot of strong extensor spasms. So it's just a position when they're on their back. When they're on their side, it's not such a problem because you can bend their knees up, but on their back this is quite a nice one to use, and it's just called frogging. So I just thought I'd put her in that position while we're getting ready. All right? Thank you. Right, okay, back to what we were doing.
Okay, so joint mobilization. So one of the problems, a major problem of spinal cord injuries, that people are not able to move. So when they're not able to move from high level as they go down, we've seen the levels of injury. So if it's a high level, C3, C4, they won't have anything in the shoulders, they can't move their legs, and no movement beyond the neck. So what happens is, over a period of time, if they are lying in a bed, the arms and the shoulders are going to get tight in that position. The muscles will get tight, ligaments will get tight, and remember the gravity. We all are fighting against gravity. So whichever position you put the person in, he's going to stay in that position, pulled by gravity. So as Sue was rightly showed, inside, curled up, right?
They're always in flexion and adduction because the muscles that bring the arm in and into this position are innervated higher than the muscles that are in external rotation and abduction. So if you've got a high cord injured patient, they will always rest here. And classically, when they're in intensive care, they're left on the bed with their arms by their side. So when you go to move their arms, they've got shortening and contracture of their pectoralis muscles here, and you can't lift their arms out. So already you're starting to lose range. So very important, just from a positioning point of view, that you're always thinking about positioning arms when they're in acute. So I'm going to show you a couple of things. You'll notice I took my watch off, and that was just an instinct. I absolutely did that without thinking. Whenever I go to handle a patient, and in my mind I was in patient mode, take off all my jewellery, and I take off my ring. I only have my plain ring too, because any clasp, claw, mounting or jagged edge of a watch catching on your patient's skin when you're moving them will cause skin damage, and they can't feel it. So we take all our jewellery off.
And infection.
It is for infection control. One of the positions we can do is to put the arms up into a position onto pillows.
So it's important to know the normal movement of the joint, that you do not go beyond the normal movement. You don't go beyond the discomfort level. The patients would be in pain. So you try to comfort them in as neutral as we say, because for neutral means you need to be within their range, not too bent, not too extended. So if you look at this pillow, you just have a look at the neck. It is slightly high, right? It's slightly big, but we didn't have anything else just then. But just see the angle of the neck. You're going to be feeling quite uncomfortable after some time. Are you already? That's what your patients would be feeling. Right? So that just you take that away. Take something which is, I'm going to use a towel maybe. right? Does that feel much better?
Yes,
But the chances the neck might roll back. So you need a slightly flatter pillow than that. So the neck is in neutral. Now you can now guess what the neutral is. Not too bent, not too extended, not rolled to the side. Yeah.
So what I've done is just given a position where one arm is slightly abducted out, so we're stretching out the pectoralis muscle on this side, and the other arm is just supported up on a pillow, and I've used rolled flannels just to posture her hands. So what we're doing is we're stopping this happening, and we're stopping that happening. And if you leave a hand flat, you're likely to start to develop deformities and contractures, especially in the presence of spasms. So we're just giving her, this is without using any splints, this is just towels and things, you don't have to have anything clever. Sometimes what we do is we'll actually just roll up a ball of cotton wool and put it in a tubey grip, and then use another bit of tubey grip and to slide it on to hold it in place so it doesn't roll off.
Socks.
So
We have used
socks,
socks.
yeah,
Fill the socks with cotton.
yeah.
And roll and just tie the ends, and you can use that as a hand splint just to position the hand.
Doesn't have to be high tech at all. And this is just really just posturing here. So we've got both hands elevated above her chest. Why?
Why? Everything? Why?
Circulation of blood circulation.
Yes, definitely a circulatory effect, because what will happen is very likely, she's not moving, she'll get dependent edema. And so her hands will start to pocket and swell. So by doing this, we're making sure we get good return, and it's going back down to her lymph and then above her heart level. So we've got arms positioned. We don't usually put both arms up because it actually puts too much of a stretch across the shoulders and the neural plexus. But what it does do is do one arm at a time. So maybe half an hour and then swap in the other and then change and start to see how that feels. And then obviously when she's on her side, we'll look at a different position. But this is just showing you some options of how you could position arms. Okay.
We use lots of towels. So these are easily available if you don't have any sponges or any special material. Towels, bed sheets, just make a roll of them and use them where the support is needed. Then she's going to go back to, I'll talk through and you can go to the legs.
Now, shall I do positioning or movements? Movements?
Positioning first and then we go to the movement.
We kind of did positioning a minute ago, but so we would probably go to that position for legs, so that we would have good support and foot up.
Why do you think we need to keep the foot up like that?
Drop foot.
Drop foot? Yep.
Absolutely. And we're de-weighting pressure off the heels.
So we remember the heel is one of the vulnerable areas, so we don't want heel to touch because the pressure is going through. And the foot drop. So over the period of time, if the foot remains like that, and a lot of you may have seen that. Yeah, we've got a picture where the foot just goes, which we said foot drop, and over a period of time, it just gets fixed in that position. So if the person would not be able to sit because the foot is always like that, or stand. There's no possibility of standing, so you prevent these complications in future. All right.
Okay. Shall I show? So we'll go through movements. If I go through lower limb movements and
Cute.
So I'm going to talk through if she was unstable and she had an injury from the T4 down, I wouldn't want to be really pulling her around too much and causing her spine to move. So what we tend to do is we don't do a full one of these, because you tilt pelvis and flatten spine, and so that's, and it also you'll set off any pull and spasm. So what we'll do is we'll put the leg out into abduction, and we'll do movements here in this range. Because you can see I'm not moving the pelvis anywhere near as much. So we're just mindful of not really moving around too much. It depends on the spasm, and really anyone really that's going to be spasming a lot would be manage that. It's quite common. They do studies. They do respiratory studies where they look at CO2 build up, and they also do breath count monitoring through the night, and they monitor it on a bit of equipment. And sure enough, quite a lot of cervical injuries do suffer with sleep apnea, so it is a problem, definitely. So heat. We were talking this morning about sensory deficits, and we were saying when you've had a spinal injury that when you do the testing of the sensory areas with the pinprick and the light touch, you should also, if you were considering using any treatment like that, you should always check hot and cold to see if they can perceive it. Now, we don't use heat because several of our patients have burnt themselves using wheat bags because they don't feel the depth of the heat. So they may have some slight feeling of heat and they go, oh yeah, I can feel the shower when it's warm. But it actually turns out they can't really feel it very much at all. Okay, we're going to talk through respiratory and hopefully it will behave itself. All right. Okay, so we'll whiz through. As we said earlier, respiratory problems can be one of our major causes of death in our patient group, particularly in our tetraplegic group. And quick revision, we've talked this through earlier. Abdominals are at the bottom of the thoracic spine. Intercostals are throughout the thoracic spine. Our diaphragms, 3, 4, 5. Our accessory muscles of breathing are up in the upper cervical spine. And our intercostals are on our thoracic spine. So if you've got a cervical cord injury, all you've got is your diaphragm and your accessory muscles. So you get very tired very quickly to build a lot of endurance. So the problems that we have, causes of our patients with high level injury, are these: inspiratory and expiratory muscle paralysis, loss of an effective cough, decreased mobility because the movement of the chest wall doesn't work, so it gets stiff, poor lung compliance, so you've got stiff ribs, and then the actual lungs themselves become like a stiffer balloon and they don't expand as well. Paradoxical chest wall movement, sorry, that's a technical word. That means that the chest wall doesn't move normally. So if we were to have a look at our patient, when you go and look at them lying on the bed, they won't be breathing and seeing their ribs moving like this. In fact, what will happen is the ribs that perhaps if they've got an injury that's high, some of the ribs might move and the rest will suck in because of the negative pressure. So you'll see a different movement and they get tired. The other problem can happen, and Fiona mentioned this morning, that if a patient has got an injury that's getting worse, that they could start off when they first come to you seemingly like they're coping very well, then they get tired, or their level of injury raises because after an acute injury you get swelling in the spinal cord. Where you have swelling, it's compressed within the bony tube, and the bony tube causes the pressure and the lesion ascends, it goes up, and in fact they could then lose some of their respiratory function during that period. So it's the first 48 hours of an injury is really, really important, really meaningful to watch and make sure that they're coping. Obviously, we're talked about associated injuries. So patients with these sorts of injuries could have a head injury. They could also have multiple rib fractures, pneumothoraces, hemothoraces, so collapsed lungs, blood in the lung into the bottom of the lungs. So really complicated pictures. The worst case scenario is an adult respiratory distress syndrome. I won't go into that now, but obviously it's massively life-threatening for those of you that are familiar with it. So just to talk about why breathing's different to someone with a tetraplegia is because their intercostals don't work properly, which means that their expansion is reduced massively. So when you breathe in and out, you blow in and out a tidal volume. Do you know how much an average tidal volume is? Does anyone know? How much do you normally shift and shunt in and out as you're breathing? No? 5 litres? 2 litres? 1 litre? Am I getting close? It's 500 mils. Tiny, half a litre. So that's what you normally have. They lose 60% of that. So they're really at risk. And that's one of our major problems. Their residual capacity, their functional residual capacity reduces, and then that means that they don't have that ability to breathe easily, and they have a difference in the way oxygen is taken up from the bloodstream into their lungs. It's called a VQ mismatch. The main problems that we see are fatigue, secretions. So we won't go into the mechanism, but there is an autonomic dysfunction action that happens in tetraplegic patients which causes them to make a lot of secretions. So when you have a new injury, the patient develops tons of secretions. It's not infected at the moment, it's just tons of it. So they're just full of bubbles, which makes it harder to actually move around. And so they have lots of bubbles, lots of secretions, but of course what happens is they don't breathe in and out very deeply, the secretions sit in the bottom of their lungs, give it 2 days, and they've got a chest infection. So you can see how we have to be very proactive with treating patients with these problems, otherwise they will develop issues of collapse and consolidation. So where you've got collapse and consolidation, you'll definitely then start to get areas of more infection and eventually lead to compromise and respiratory arrest. So what we do is we actually very proactively will ventilate somebody that's at risk. And we make that decision looking at what their vital capacity is. Does anyone know what I'm talking about when I say vital capacity? Okay, vital capacity is the ability to take a breath in and blow out as long and hard as you can and to see what your capacity of your lung is, your lung field. So a big guy has a vital capacity of 6 to 8 litres, a really fit Olympic swimmer, probably more, and a really fit female swimmer who's sort of about 5'7", 5'8", will have a vital capacity of about 4.5, 5 litres. Me, about 3.5 to 4 on a good day. So all depends on your size and what you were doing and how you were training. So if they have a very at-risk vital capacity, we will ventilate them, and we say that's anyone with a vital capacity of under 1 litre. So 1 litre is our cut-off, and that's an evidence-based decision. That wasn't just a, let's go for that. That's been from research that we've looked at, and over the years people have decided that's a good cut-off point. I mentioned on their pulmonary embolus, just to remind you that in the case where somebody's had a lot of chest trauma, that's a likelihood as well. Okay, other things that we need to worry about. Paralytic ileus, we haven't talked about that today. We did. Fiona talked about it when she was talking about gastrointestinal complications. And that's basically because all of that just stops due to spinal shock. So your bowel isn't working normally, and you'll get a complete shutdown, and then you can actually then have a very dangerous situation where you are not moving anything in your gut. And if we then go along and do loads of chest physio and assisted coughing, which I'm going to show you in a minute, could actually cause massive rupture of the bowel. Head injuries we've talked about, broken ribs, fat embolus coming from any fractures. So if you've got any major fractures, you're likely to have a fat embolus as well as the other injuries. And any pre-existing cardiovascular conditions. So if somebody already had a pulmonary condition or a cardiac condition before, then obviously you're going to have to consider that they're a higher risk because of their injury. So what do? Well, we use that little gadget there. It's called a microspirometer, little handheld gadget, and some ridiculously expensive little gadget. We have to use one that's completely wipe cleanable for infection control, so the buttons are completely smooth. And it has a little turbine, and the patient blows into it and gives us their vital capacity, and it also gives us their other respiratory functions, which we use in other ways. So it's very quick and easy. It tells us exactly what we need to know. We also look at their general observations to see what's happening with their oxygenation and their oxygen saturation. We look at their respiratory rate. If their respiratory rate's very high, you know they're struggling. What we have found is that looking at blood gases, if you're using an oxygen saturation monitor on someone's finger and you're going, oh, they're fine, absolutely fine. Look, saturation's 97, they're doing fine. They're coping okay, they'll be fine. Let's pop them off to the general ward. We don't need to keep them on the HD or ITU. And in fact, they're just getting tired and you're not noticing because they compensate so well. So their saturations are fine. But if you put a CO2 monitor on and look at their CO2 levels for the medics in the room, their CO2 levels will be rising. And we use a CO2 assessment rather than an O2 assessment to decide whether someone's coping or not. So it's just a tip that we would use. We also look at their gases, have a look at a chest x-ray. We look at the chest movement. As I said, we're trying to see what's moving. If they've got lots of rib fractures, we might see a segment that's moving on its own, a free segment. And we listen. We listen to the chest, see what we can hear. Can we hear breath sounds? Is it full of crackles? is there areas that are completely silent, and if there's an area completely silent, then they've plugged off, as we were talking about this morning, where they've had a big plug of sputum and they've actually just completely lost that whole lung field, and so that you'll need to do some fairly aggressive physiotherapy to actually move that. And well humidified, humidification again. We use something called a peak cough flow. We don't do this initially, we do it when they're actually a little bit further on. And peak cough flow has been shown to be a far more effective way of assessing someone's ability to cope and also to show improvement. So we actually use it, we get them to actually cough into a little gadget like a microspirometer. I've got a picture of the other thing, which is a peak flow meter. You know, when you do for asthma, you blow into one of those red peak, I've got a picture. We use one of those to do the peak cough flow. And that gives us quite useful information about their respiratory function. Okay. And we talked about pre-morbid factors. So, having looked at the vital capacity, we can use things like a bird, which is just a PEEP support system. It gives you a nice big blow. The patient initiates, sucks in, it blows the air in, and it just gives you a big expansion. The reason we use it is it gives us a big expansion that we can use for chest physio, so we can clear the secretions. That's why we use it. Otherwise, we'd be using a ventilator, or we would now use a Clearway, which is a cough assist machine that has the ability to provide you with a PEEP end expiratory pressure, which gives you that big breath in that you need. So, just going to show you somebody breathing, which is why I wanted this. Now, please work, otherwise I'm going to get really upset. Oh my God, it's a miracle. It's because you came in. Yes, there is. Okay, don't worry. Okay, so this is an assisted cough. Did you get it? Did you blink and miss it? This gentleman has a very, very, very stiff chest. He has ankylosing spondylitis. And he was taking so much chest physio. Again, play again. Okay, so you watch. So this is one nurse. He's a strong guy with my patient here, and he's doing his breathe in and out. Breathe in and out. Breathe in and cough. It's aggressive, isn't it? Far more aggressive than you realise. This is one, we normally do it bilaterally because this gentleman, Trevor, is very strong. He was doing it on his own. So what I need is someone to come up and have a go, and then I'm going to get a couple of you to come and have a go. Right, who's going to come and do an assisted cough on my pillow with me? Come on. Somebody come here. Anyone? Anyone? Quick, quick, quick. I'm going to grab a few more of you and make you come and do it in a minute. Right, this is our patient. This is our patient's head. No, you're not having to be a patient. You're going to be a therapist. Right, you're going to put your hand here, just here, like this. So what we would do is this would be our patient's chest, hand on the side, hand on the side. This is the side of the patient's chest. And what we do is we do a scoop, and the scoop is down into the pillow and in. It's a semicircle arc like that. And so we take the patient, breathe in and out. Not yet. Breathe in and out. And on this one, breathe in and cough. And it's really that aggressive. So we do it bilaterally, so it's squeeze and push. That's one of the techniques for doing it. Okay? Right, anyone else? Anyone else? Come and have a go. Quick, quick, quick. Thank you, well done. Well done. Right, here you go. Come and try on this one. Come and try this one. So handle there. So hand there, hand there. So you breathe in and out. Breathe in and out. Breathe in and cough. Lovely. Spot on. Brilliant. So it's really deepening and it's quite a forceful thrust, okay? Have a go, girls? Yeah, so the patient's head's here. All right. So one hand here. I haven't got the bed the right height for you guys, you're very tall. Okay, and then that hand there, and that hand there. Okay, and so you say breathe in and out. Breathe in and out. And then this one and cough. And it really is in and up, okay? So it's quite aggressive, which is why I was saying you wouldn't do on somebody who had paralytic iris, because it would cause all sorts of problems. I just wanted to give you a feel of that. He's going to behave now. We need to get back to the presentation. Sorry, just last couple of slides and we've done on this one. Lovely. Now you've got that back, right to the end. Okay, so as you can see, patients with a high cervical problems are very much at risk of respiratory compromise. So, as I said, we would use a cough assist machine. One on here, there, is the old one, that one there, and the Clearway's the new one, both of which are equal value, but Clearway does BiPAP, which is quite handy. Okay, we also use small respiratory training devices to help people increase their breathing and to strengthen their breathing muscles. And these are some of the other techniques we use. So we'll use breathing techniques called breath stacking and bagging. I don't know if anyone's familiar with those. They both need to be done carefully by somebody who knows what they're doing. Right, these are not things you just have a go at. You have to be trained how to do these because you can actually cause someone to pass out doing breath stacking if it's not done properly. And bagging is a technique that's used also if you're trained to do it, because you can cause damage by pushing too much air in through the bag. So these are techniques we use, but you do have to know what you're doing. Okay, I think we'll finish there. Just going to go through. There are other techniques and other bits of equipment and kit that we use. We've got a vest that you wear that vibrates your chest that helps move the secretions. Just wanted to show you my lady in the hydrotherapy pool who was ventilated. So she was a central cord injury. So she had legs, but really poor trunk and upper limbs, massive whiplash, horrendous car crash, on the ventilator walking. So they're rare, we don't see lots of them. And this was really the first time we'd got her walking, and it was in the pool. So you can see, look at the length of that tube. Imagine how hard that was to manage from a ventilator setting. So our anaesthetist turned up in an old-fashioned bathing suit like I used to wear years ago, in a blue and white stripy all-in-one bathing suit, stood there and went, "I'm ready." And he came with us. Came in the water as well. It was really good fun. So, and I just wanted to say, I told you about the phrenic pacing this morning, about using electrical stimulation on the phrenic nerve to get breathing.